Tēnā koutou katoa. Ngā mihi nui ki a koutou katoa. Ki Institution of Engineering and Technology, tēnā koe. E ngā tangata whenua, tēnā koutou, tēnā koutou, tēnā koutou. Ko rangitoto te moanga, ko pahurehure te awa, he haina mana aho, no te tamaki makoro aho, ko Angela Lim toku ingoa, no reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora, everyone. My name is Angela. I started off this session with just sharing a bit of my background here in Aotearoa, New Zealand, and just really important to be able to acknowledge the Indigenous Maori population of New Zealand in sort of this story. Sort of my background is I train as a pediatric doctor and have always been really passionate about improving patient outcomes, and this talk here is really a chance for me to share sort of things that I've learned and the applications of technology in really improving access to care. For those of you who are in the industry, you can't escape sort of artificial intelligence being very top of mind. It is the new frontier, and it is one that is coming much sooner than one expects. And in my sort of industry in healthcare, we're really starting to see some of that emerging technology come through. And I'm going to share with you a little bit about my experience with AI in the company that I have started called Clearhead. But maybe before I go there, let me tell you a little bit about my background and what got me to starting Clearhead. So I trained as a pediatric doctor and really loved working clinically. You know, it was a typical day for me would be from seeing babies to children to being in the surgical theater. And there was so much that I felt like I could contribute as a doctor, but I also was very frustrated with the fact that my time was always very limited. There were only 24 hours in a day, and there were only so many patients that I could see at any point in time. And yet I felt that I was really not even meeting sort of this true need of what people have, and sort of this idea around that the people who I get to see in the hospital very much the crisis points where the ambulance at the bottom of the cliff, but there's a large majority of people who could have been better supported out in the community so that they never got to the crisis point. And yet at the same time, for those in the community who wanted to be seen, there was often a lot of shortages, not just by doctors, but really a lot of other health professionals as well. And so what that results in is sort of these long wait times and poor outcomes, because people are very much being quite reactive to the care that they get. And then at the same time, if we were saying that the demand for healthcare is much larger than the supply available, which is the human workforce, you know, we were not really tapping into technology in any in any meaningful way. Even though I graduated from medical school in 2015, which was not very long ago, I was still using pages, I was still using fax machines, and these were all technologies that really should be left in the 1960s, which was when they were most predominantly used. And so it really got me thinking to what about these emerging technology that we could apply to really improve access to care and augment the limited workforce that we have, so that people really can get care 24/7 that's personalized to what they need. And when I think about this issue around access, it was the most acute in mental health, where when you look at the statistics, only 5% of the people who need it actually gets it. And that's reflected both in the proportion of the workforce available, as well as the funding that has been allocated. And so we see that actually about 95% of public mental health funding actually only goes to about the 5% of those in the pointy end of the spectrum. And yet if we had 100 people come to the emergency department and 95 of them turned away, we would have a public uproar, because mental health is very much an invisible problem. We don't sort of have the same public backlash in terms of accountability and change. And I really believe that care should be a fundamental right, and that if it could be accessible to everyone and it's personalized to their specific issue, that's when we're really going to start seeing that change in outcomes to be more equitable. And another way to think about that inequity in care is that 40% of our mental health service users in New Zealand are Māori, the indigenous population. And yet, less than 4% of our clinicians are Māori. And what that really means is that unless we magically 10x our Māori workforce, we're not really going to be able to consistently provide culturally responsive care to the large proportion of people who require that support. There is really an opportunity to think about what is the role of AI in augmenting our workforce. But maybe before we even think about what that opportunity is, maybe we can think about what the history has been. And so this idea of like AI in healthcare might seem like it's really picking up steam over the last few years, but actually it was as early as 1950 when Alan Turing, a British mathematician, sort of asked the question whether machines are able to think and be like a human, was when that's when artificial intelligence sort of seeded. And I'm sure you've heard of the Turing test as a way of thinking about how likely is the machine to be able to perform as well as a human. We really start to see sort of that picked up in the 1970s, and there were really two types of application. There was the application for structured data, which is easily coded, and the application of machine learning, as well as unstructured data. So these are the stuff that you see in clinical notes, which requires a bit more natural language processing. And really it was sort of in the last decade that we really start to see some of that performance of domain-specific tasks really actually performing on par with human experts. For example, breast cancer detection, and in fact, in some cases actually outperform human the human medical workforce, especially in the case that if this is not something that you see often. For example, if you're a general practitioner, you are not a radiologist, and you're just looking at a radiology scan, you're more likely to miss it because it's not something that you're picking up regularly. And then where sort of that evolution of that intelligence is coming is whether it's kind of in the boundaries of what they call supervised learning, which is when the clinician is sort of teaching the machine very explicitly through sort of labeling this as this is a cancer boundary. Versus sort of unsupervised learning, which is much more undefined, both in terms of the training models, training data that is provided, as well as the definition of the constraint of the task the machine is put into. And that at this current stage of the technology does have safety and ethical consideration, because often with unsupervised learning, the requirement of these large data sets often does introduce bias and unwanted outcomes. So let me give you a really simple example. If we, for example, know that we have a very high do not attend rate in the clinic. So let's just say 20% of clinic attendance, we have the patients not show up at all. And if we were to kind of feed the machine all this data and historical data to with the outcome that we want to reduce the do not attend rates in sort of outpatient clinic, we were actually introducing a bias because if we look at those rates, yes, they are often skewed to more Maori and Pacifica patients, but we don't often recognize that there are other social determinants that affect why they were not able to come to the clinic. Maybe they couldn't take time off. Maybe they couldn't find someone to do help with the childcare. Maybe there are cost implications to traveling. And if we sort of allow the machine to kind of optimize for allowing patients who are less likely to not attend clinics, we would then actually introduce bias against Maori and Pacifica who already have poorer health outcomes than non-Maori. And what that means is that you allow the machine to perpetuate health inequities. And so there are often these considerations when looking at how we use technology to improve outcomes that have unintended consequences that comes from biases that if we're not sort of explicitly accounting for them. So having that understanding of sort of like my motivation of why I started Clearhead and in terms of the problem I wanted to solve and sort of where the history of technology has been, I really thought about, okay, well, what does it mean to truly build a very patient-centric mental health system? And in this case, for me, a health system is very much in its simplicity, simply services provided and services received and payment made for that service. That's all it is. And so a patient wants that service, the provider provides that service, and someone then pays for the provider's services, whether that's the public taxpayers, whether that's your health insurance company, whether it's out of pocket. Regardless, that in its simplicity is what a health system is. And so when I thought about that and what were all the barriers that stopped people from getting help, the first was sort of that initial part of that process, which is like that initial triage. Do I know what I need when I need it? And then when I do know what I need, can I see that and get that service very quickly and it's personalized to me, and then for me to kind of really have that services paid in a cost-effective way that is not going to be, for example, like in the US, going to cause bankruptcy. And so what Clearhead had essentially built to solve this problem was to build a digital end-to-end mental health service from triage to treatment. And the first part to sort of improving the supply constraint of the fact that we did not have enough psychologists in the system was to build an AI therapist where we've sort of written our own conversational AI model to be able to provide that sort of personalized support anytime and anywhere and truly have it be available 24/7, including being able to provide more culturally responsive support through delivering the support in not only a Te Ao Māori worldview, but also to provide it in Te Reo Māori, which is the indigenous language of the Māori people. And then for those that are not able to be adequately helped with the AI therapist, we built the largest national directory of therapists in New Zealand. We have more than 300 across the country that were able to see you in person or online. And we've automated that coordination of care. And just to give you an example of a typical user experience is that the user had reached out to book therapy at 11 p.m. on a Sunday. on a Saturday to be seen at 2 p.m. on a Sunday. And that whole process went through seamlessly without a human in between. And basically, we've been able to deliver sort of within 14 hours from when someone reached out for help to when they've been seen, and for us to pay the service provided. And this happened in person and happened after hours, again, similar to sort of automating the role of triaging for support. We were able to automate that coordination of care. And so really what we've been able to provide with that triaging process is those that are in crisis, they are immediately helped through a free helpline. Those that are sort of severely unwell and just need to be seen by a therapist are able to find and be matched to the right therapist. And then for the large majority of people who kind of just want to learn how to self-manage or help themselves, the AI therapist can really guide them to do that. And of course, the system needs to constantly be proactive and changing trends. For example, if you think about the Christchurch terrorist attack, gun violence was not something that was familiar to New Zealand up until sort of like 2019. And that's something that we sort of saw a trend around people needing support. Because we actually started Clearhead in 2018, back, sort of before it was very sexy to work on mental health services. And the idea really is, like I said before, is that how do you make sure that what you've built is safe and effective, but also manages the risk. And that's the main thing often when introducing AI, is that are you managing that risk? And we very much are constantly triaging and assessing risk in real time. And so what does that AI therapist look like? It looks like this. It's like you're texting someone on the other side, but it's actually just completely supported by a machine. And it can even sort of have conversations with you around what it is that you are pragmatically needing support around. So it's not just like, oh, you've got anxiety, but actually, how do we really support you to build self-awareness? How do we really support you to feel empowered to tackle the core issue of what's causing any sort of distress to you? And that's really that element of personalization. But also, what does it look like when it doesn't look good? And so here's an example where we've had a go at trying out GPT-3, and really you can see in this case, it's like this person reached out because they were feeling really lonely, and the machine sort of reply was, well, you'll be alone forever, and that's can be incredibly triggering for people. And so these are the things that you are really trying to manage against. And what then happens is that if you are able to provide something that is empathetic and helpful, you really start to see that clinical outcome that we wanted, which is that instead of people waiting years to be helped, they are getting immediate feedback and support when they reach out, and they're going through that sort of help-seeking journey much more quickly through the different stages, and moving from denial phase or pre-contemplative phase to one where they are actually able to say, yeah, I'm ready for help, and yes, I know this is affecting me, and this is what help I need. And so where is sort of these conversational AI models like what Clearhead has built go moving to, there really is these very exciting opportunities around the fact that actually some of the research have demonstrated these neural network models that are being built are actually very similar to mimicking language processing centers in the human brain. And for example, at the moment, the Microsoft and NVIDIA model actually have 530 billion parameters in which they are training the algorithm to be able to pick up on. And really moving past sort of these pre-set templates is the ability to then start to really deeply understand the context, make the inference, and then actually generate a response. And really most importantly, again, around that safety element, understanding sentiment against intent. So what I mean by that is someone sort of reaches out onto Clearhead system and said, oh, I'm so happy that I'm going to kill myself because all my problems will go away. If you kind of sort of use these out of the box solutions, it will actually say, oh, that's great, you should do it. Versus sort of, Clearhead system has been, we've built in these risk parameters so that we knew the sentiment versus the intent. Yes, it might come across as a positive sentiment because they say they're happy, but the intent was negative and that it was a suicidal risk that we had to manage. And that really, as you sort of continue to build upon that memory and knowledge graph and the ability to respond in an empathetic way and across multimodal responses, including, for example, providing cat memes, you really start to build a personality that people can really build that relationship against, even though they are a machine, not a human, and really challenge sort of this idea around passing that Turing test in the not very far future. So really, our mission is that in order for us to provide personalized support for everyone, we need to build an AI therapist that can deliver therapy on power the human psychologist. And I'm incredibly excited to be able to share that experience with you around where our journey has been to date and where we're going to go. So thank you so much for taking the time to listen and learn about Clearhead, and I wish you well.
Hi, Angela. Thanks for joining us.
Hi, Andy. Thanks for having me.
Thanks for that great presentation. It's great to see AI being used in that mental health care space. It's obviously something that we've got an issue with here in New Zealand. Thanks for all the work that people such as yourself and Clearhead are doing in that space. So we've now got a few questions. We'll start with what impacts have you observed in the mental health space in New Zealand as a result of COVID-19? And I guess in particular the lockdowns themselves.
Yeah, it's actually quite depressing, like no pun intended. But so being available nationwide and been sort of available since pre-COVID, we've been tracking sort of the sentiment of the country for the last 3 years. And what's been really concerning is just this ongoing decline of sort of people's overall mental health. And in the last lockdown, which has sort of been going on in Auckland for really about 3 months now, we've really sort of seen a plummeting of sort of where people's at. And you see that sort of in sort of people's sort of frustration with each other, sort of even dissatisfaction at work when sort of work isn't even the direct relation to why they're unhappy. And so, yeah, we are really concerned because the mental health system had always struggled with being able to meet the demand, and with what we're seeing and the fact that there just isn't sort of like sort of adequate proactive support to prevent sort of these ongoing decline, we're really sort of pushing the problem out, but we will sort of see the repercussion of it very soon, and I'm really worried about that.
Okay. All of our talks today are about the application of technology, but this needs people with the interest and science in skills and technology and engineering. How does Clearhead find and support technical talent in New Zealand? I guess, what are your views on how we attract the next generation?
Yeah, it's an absolute talent war at the moment, to be honest. We just cannot seem to be hiring enough. And this is us as well, we would consider ourselves a small startup. And yeah, we've been trying to hire over the last 2 to 3 months. And it's not, it's just, I think, just not enough of that talent out there. So I think fundamentally it comes down to ensuring that we're really seeding the ground in terms of making sure that sort of STEM education is really sort of in the awareness of young, sort of even really at a very young age, and obviously through age appropriate type of education is super important. And then really for those that sort of like where we're at is that as a small startup, it's very hard to kind of sort of be the training ground who are often just sort of like so stretched and doing a million and one things. So there's a real opportunity for some of these bigger institutions, including academic institutions, to really sort of be growing the talent in terms of the seniority and experience, and allowing sort of then smaller organizations like ours, who can be more nimble around sort of the cutting edge of technology and innovation, to then sort of tap into that talent and then sort of give them a bit more sort of free reign to explore the applications, but they have a very solid foundation in which they have been trained upon. And I think that we're really seeing a dearth in sort of the middle, which is like, you know, they're all either fresh graduates or like they're sort of very senior and commanding sort of, you know, too easily somewhere between $150,000 to $250,000 a year salary, which is completely out of reach for small startups.
Are you seeing the right sort of quantity of young engineers coming out of the universities though, or is there still an issue?
No, I think that's an issue. I saw a recent report that actually saw a decline in people entering engineering, especially software engineering, which is completely counterintuitive if you expect that basically software is eating the world and every single sort of sector will have some level of technology application, and we're all fighting for the same small pool of people. And it's very concerning for me that we are seeing a decline in sort of at the graduate level coming, sort of people undergraduate level coming in, because that to me signals that like we are somehow not preparing our young people to realize where the job opportunities are and where that talent needs to be.
Yeah, okay. Question came. Question on privacy concerns. So what sort of privacy concerns and challenges do you see with the use of AI in this field, and how are they addressed by Clearhead?
Yeah, fundamentally, I think there's still a huge conversation around sort of what is data sovereignty, and I think the sort of the movement towards blockchain is an example in which sort of like the societal zeitgeist is moving towards sort of like people wanting to own their own data without sort of having their data be sort of like these large companies sort of the new goal in some ways. And so really the first question that all company and all public organizations and government entities really need to be very upfront and sort of shifting towards like data sovereignty is very clearly with the user. And that's something that is stated in our privacy policy. So we wanted to lead from that example. The second is really thinking about like sort of the role of encryption and sort of security in how information is stored. And this again is really important, especially when sort of inputting sensitive information like mental health. And so we were very committed, and in terms of both applying encryption in terms of end-to-end encryption with the information that's provided, but also then around sort of how the buckets of information are broken up, so that if a part of the system is ever hacked, that it's not that every single identifiable information for that individual is disclosed, but actually these are maybe one part of the bucket out of 10 buckets, for example, is compromised. And so it is still technically relatively gibberish and relatively not able to be sort of pegged into any single individual.
Okay. In terms of the conversational AI model, and in particular memory and knowledge graph for content, are these chatbot memories only applicable in that session, or is that sort of data, are we talking about that being available to be recalled later?
Yeah, essentially, I mean, ultimately, if you think about the ability to have contextual information, memory needs to persist beyond the existing session, and that is something that we apply. Okay.
Another key thing within the chatbot was the ability to converse in Tureo, Maori. Mm-hmm. What was the biggest challenge in sort of teaching that language?
Yeah.
And I think we all realize that necessity, so.
Yeah, the biggest challenge really is around sort of the ability to keep things up to date. So if you think about the fact that, let's take machine learning, for example, right? So a lot of the databases in which machine is being trained upon and these models that are built, they're often built in English. So the machine has some level of being able to pull upon training models that it can sort of build upon, but you don't have that same level of foundational layer into their modeling. And so if you think about, like, for example, this whole thing around sort of neural network sort of response generation, so that really essentially is saying that the machine is able to generate its own response. So it's not requiring it's not using sort of pre-written templates. And so it's possible to do it in English because there's lots of like sort of models and foundational training data that's available in English. But then you now say that, like, to do that same capability in Tereo is almost impossible because one, there is that data set is not available. And second, you can just think about it, just like, how comfortable are you just even to use Google Translate? So if you, as a person, is going to type in like, okay, hi, my name is Angela and I work at Clearhead. Now, plug that into Google Translate, and then and the confidence in which you have around that Google translation will probably give you the same sense of confidence in which even if that layer could even be doing one, multiple layers deeper around sort of like the training of the conversation model. So that really is the biggest challenge with sort of non-English data sets.
Okay, thank you. Okay, what's next for Dr. Lim? Entrepreneur or return to day-to-day medicine? Where do you see yourself in say 10 years?
Yeah, no, I mean, in 10 years, I would love for Clearhead to be like the #1 sort of go-to sort of digital mental health platform. So for me, it's sort of really the ambition of sort of what does it mean to scale up the impact of what we've done. We've been able to, through New Zealand, proven out and supported about 14% of the population. What does that now look like if we can support wider? Because it's really a global problem and we've developed a global solution. So really, if there's anyone listening who would love to help us, bring us across to wherever you are in the world, we would love to talk to you.
Great. Thanks very much. Thanks for the presentation. Thanks for your time, Angela.
Thanks for having me, Andy.